Okay, hello, and thank you for joining the Cultural Competency webinar brought to you by the State and Community Intimate Partner Violence and Perinatal Depression Resource Development Project. My name is Keisha Highsmith from the Health Resources and Services Administration, Maternal and Child Health Bureau. Today's webinar is one of a series of webinars that HRSA MCHB and Social Solutions International, Inc. will be hosting to discuss select topic areas that are addressed in the newly developed resource toolkit entitled A Comprehensive Community-Based Approach to Addressing Intimate Partner Violence and Perinatal Depression. Next slide. Today's moderator and guest speakers for the webinar are Kristen Steer as moderator from Social Solutions International, Inc., and myself. And our two guest speakers are Dr. Suganya Sagalingam and Ms. Darby Taylor. Dr. Sakalingam is from Change Metrics, and Ms. Darby Taylor is from Des Moines Healthy Start Project. Next slide. The objective of the webinar is to discuss the importance of cultural and linguistic competency when addressing intimate partner violence and perinatal depression. Also to discuss tips and tools on how to examine your organization's cultural competence, and discuss staff development tools that focus on cultural competence. Next slide. As I mentioned before, today's webinar is one of a series of webinars that will be discussing select topic areas from the resource toolkit entitled A Comprehensive Community-Based Approach to Addressing Intimate Partner Violence and Perinatal Depression. The goal of the toolkit is to provide a guide that is culturally and linguistically appropriate to support community-based programs with making the case for why it's important to address the intersection of intimate partner violence and perinatal depression. Also to assist communities in reducing stigma and provide strategies for building partnerships and increasing support from leadership, both to ultimately improve the health and safety of families experiencing intimate partner violence and perinatal depression. The toolkit is scheduled to be released this fall, 2012. Until then, we hope that you join us for the upcoming webinars and enjoy today's presentation. Thank you. Kristen?
Great. Thank you, Dr. Highsmith. And now we're going to hear from Suganya from Change Matrix.
Good day. It's my pleasure to provide this presentation on cultural and linguistic competence as part of the webinar series sponsored by HRSA's expert work group on intimate partner violence and postpartum depression. Today, I'm going to explore cultural and linguistic issues that impact services to women who are experiencing intimate partner violence and or postpartum depression. I will then share a framework for ensuring that services are culturally and linguistically competent. In partnership with two other women, Rochelle Espiritu and Elizabeth Waitzik, we manage a company called Change Matrix, and our tagline is that we assist organizations motivate, manage, and measure change. Clearly, the integration of cultural and linguistic competence is one such systems change, and many organizations are addressing this compelling need in our society. Next slide, please. In this presentation, I will first address the demographic shifts in our population and the number of women who are impacted by IPV-PPD, especially women from culturally diverse backgrounds. We look at intimate partner violence and postpartum depression separately, and then look at refugee women who are impacted by these factors and their complex needs, including information and services in other languages. We also will explore diversity in greater depth and understand how these women are influenced by a variety of factors beyond race, immigration status, and language needs. We will then look at how health is influenced by our culture and our values. Lastly, we will explore a framework for cultural and linguistic competence that will provide organizations and providers to develop a systematic approach to providing services in a culturally responsive and competent manner. Next slide. As the U.S. society becomes increasingly diverse, providing services within health and human service systems has become increasingly complex, as is working effectively with colleagues within organizations and systems of services and care. The widening disparities in health status makes it imperative that these systems transform to address these health challenges. This goal supports the Department of Health and Human Services Healthy People 2020 agenda that looks at improving the quality of services and addressing health disparities. Transformation requires an awareness and understanding of diversity, cultural identity, and their impact on our behaviors and practices related to health access and utilization, both at the provider and consumer level. Next slide. Why demographics? If we do not understand who's experiencing intimate partner violence and postpartum depression, then it is hard to provide services in any truly meaningful way. We have to know who, where, what, and the why of women impacted by intimate partner violence and postpartum depression. So here are some current data. Next slide. Next slide. This is the lifetime prevalence of rape, physical violence, and/or stalking by an intimate partner by race ethnicity data. This data is from a survey that was conducted by the Centers of Disease Control and Prevention called the U.S. Women National Intimate Partner and Sexual Violence Survey 2010. I actually have the resources later in one of the slides. The comparison clearly indicates group with the highest incidences of physical violence and a combination of all three, rape, violence, and/or stalking. Next slide. As you can see, women are more likely to report postpartum depression symptoms. And the women who are likely to do that are younger women, those with lower educational attainment, and women who would be receiving Medicaid benefits from their delivery. Non-Hispanic white women also have a lower prevalence of PDS compared to women of other racial and ethnic groups. So you have not only a racial ethnic difference, but you have an age difference, socioeconomic difference as well. According to the CDC, minority women are more likely to describe postpartum depressive symptoms than are non-Hispanic white women. Next slide. Okay. I think, yes. It is not easy to gather data on, surprisingly, it's not easy to gather data on postpartum depression. In our research, we spent numerous hours scoping out the research and was unable to obtain national data. We were able to locate data by for some states, and we also found, yes, the other category that we had was Asian Pacific Islander, American Indian, Native Alaskan, and other multiple race ethnicity. So you can see it is hard to find data. What we do have is that the dynamics is different in terms of communities. So in the next slide, what we're able to find is that many immigrant and refugee women experience intimate partner violence in the context of language difficulties, confusion over their legal rights, and the overall stress of adaptation to new cultural and social structures. While exercise of power and control underlies all intimate partner violence, many immigrant and refugee women are especially vulnerable because of poverty and other factors. Some of the factors are limited language proficiency. Clearly, foreign-born women who have limited English proficiency are unable to communicate very effectively, and therefore they are dependent on their perpetrators who have greater English language skills, and this therefore silences them effectively. Another factor is disparities in economics and social resources. While intimate partner violence cuts across all social and economic classes, it can affect them in terms of the relationships, unequal social and economic resources that makes them vulnerable to their partner's power and control. You see this across the board in many different relationships with that level of power differential. These immigrant and refugee women are also sometimes very socially isolated due to language and the fact that culturally they may not be the face of the family or the community outside. And finally, immigration status. When the immigration status of a woman is vulnerable, if she's dependent on her perpetrator for her immigration status, it becomes very clear that that power differential puts them at a disadvantage. Next slide, please. Here are some resources if you're interested in looking up more details. What I'd like to do now is to go to the next slide and have a conversation about diversity, culture, and values. In thinking about diversity of the women who have experienced intimate partner violence and postpartum depression, we have looked at women of different racial ethnic backgrounds, women who have different immigration status, and women who speak different languages. There are a variety of other factors that we sometimes fail to consider. It is critical when we talk about diversity that we truly understand the scope of this term. On this slide is a list of in the next slide is a list of internal factors that influence individual and group identity. These are considered internal because they influence how individuals and groups see themselves and the way in which they experience life. For example, you may have a woman who has come to the U.S. as a refugee from Somalia. She is Muslim, and her worldview is informed by her religion. It also influences how she may understand and experience family dynamics and her role in it. If she experiences intimate partner violence, she may never be able to see this as physical abuse and a violation of her individual rights. We can go down the entire list and explore how each of these factors influence the way we perceive ourselves and our families and communities. People can belong to a variety of groups, and the groups they belong to often inform the culture of individuals in that group. That is why each individual has a unique cultural identity, because it is rare for two individuals to belong to identical groups that has influenced them in exactly the same identical ways. Next slide. Just as internal factors influence how we see ourselves in the world, external factors also influence our perception of the world and how we interact in it. For example, if a Native American woman experiences institutional bias on the basis of her tribal affiliation, it is unlikely that she will share issues as personal as intimate partner violence or postpartum depression when she comes into a WIC clinic to collect WIC checks for herself and her child who is eligible for this program. Yet the WIC program, which is the Women's Infant and Children Supplemental Nutrition Program, is an excellent gateway for addressing IPV-PPD, since women during the childbearing years may be coming in for services both during the pregnancy and postpartum period. External factors such as bias, political climate, community economics may negatively impact the perception of the service organization where they might access care. It may make clients uncomfortable with sharing information with providers and the agency. When it comes to sensitive issues, the barrier is sometimes almost insurmountable unless as providers we actively plan for and address these issues with our clients. Next slide. Sometimes this conversation around culture and diversity is fraught with a lot of high emotion. So I thought I would just share a little bit to break that. As you can see in this cartoon, here's a conversation between two characters. The challenge in recognizing diversity is not to make assumptions. In general, all humans categorize data. It would be difficult to live in a life in which one is bombarded with millions of pieces of data without putting them into some kind of order. That is why we identify, categorize, and put information into compartments, like knowing all the different shades of green from all other colors and putting them into that category or label. However, when we start labeling people by these broad categories or factors of diversity, we lose the individual identity that determines how they understand or even practice health. It is critical to be able to differentiate and to ask when we do not know. As in this case, here is a dolphin who is mistaken for a porpoise and thinks that the alligator is a crocodile. So you can see it's easy enough to make the mistakes when we make assumptions. Next slide. There are many ways in which people describe culture, as you can see on this slide. As many texts or books or articles that you pick up on culture, you will see as many different definitions. What I'd like to do is use a definition that sort of underlays the assumptions I make in this presentation, and that is that culture is a sum total of the way of living, including values, beliefs, standards, linguistic expression, patterns of thinking, behavioral norms, and other types of communication, which a group of people has developed to assure the survival in a particularly physical and human environment. It can also be thought to be an integrated pattern of human behavior, which includes thought, communication, language, beliefs, values, practices, customs, courtesies, rituals, manners of interacting. Culture is shared by all or almost all members of a group. Culture is passed from generation to generation. It shapes our behavior and it structures our perceptions. A way I like to think of culture is that culture is the way you do the things you do. Another way to understand culture is by using an iceberg as a metaphor for culture. How individuals are perceived by the world and how they are in actuality in the world can differ by how much we understand of what is in our consciousness and what is out of our awareness. Just as 9/10 of an iceberg is out of sight, is below the waterline, so it is 9/10 of an individual or organizational culture. It's out of our consciousness. The top of the iceberg represents manifestations or surface levels of the organizational culture or the individual culture. They're primarily in our awareness. For example, the way we dress, what we drink, the structures of our organizations, our food, our music, all of those are in the awareness. The lower levels of the iceberg operate unconsciously, are shared by all members, and defined in a basic way the taken for granted view of the individual and the organization and the environment. They are out of awareness. They're like their values, their assumptions and beliefs, all of that guide human behavior. To change the individual or organization, you must be aware of all the levels, because most often it is very critical that change must take place below the waterline. Next slide. I'm always awed by this photograph. It can be deadly when we come across it unexpectedly. We do not realize the immense nature of culture. Culture is like this iceberg. Because what happens is in the relationships is what's underneath that usually creates a lot of the tension and the challenges we face. We make all kinds of incorrect inferences based on the little bit that we see, and therefore using the iceberg as a metaphor for culture is a great teaching tool. Next slide. Another aspect of a human identity that influences the way we see the world and the way we practice health is our values. Values are the subjective reactions to the world around us. They guide and mold our behavior. They have following characteristics. They're developed early in life and often resistant to change. We do change, but we often resist it. They develop out of our direct experiences with people who are important to us, particularly our parents. They rise out of not what people tell us, but often in the way they behave towards us and others. They define what is good and what is bad. They tell us what is right and what is wrong. They do not really involve any external standards. They're usually internal definitions of right and wrong, good or bad, of the individual, of the family, of the community, of the country. Values themselves cannot be proven correct or incorrect, valid or invalid, right or wrong. There isn't a universal value as such. If a statement can be proven true or false, then it cannot be a value. Value tells us what we should believe regardless of any evidence or lack thereof. Now, a way to understand values are that they are on a continuum and people can flex along the continuum dependent on factors such as age and experience. So if you can look at the first pair, you have fate on one side and personal control over life on the other end of the continuum. And another way in which I actually talk about this is that in fate, the locus of control is outside of the person. And in personal control, the locus of control is within them. They are both on the same continuum. They just happen to be at different ends. And individuals, groups, communities fall in many different places along the continuum. And where there is differences in where they are, the difference, the level of difference is what creates a lot of the conflict. Next slide, please. So let's talk a little bit about cultural influences on health. Much of the conflict and challenges encountered when integrating cultural and linguistic competence into the U.S. healthcare system comes from the dilemma regarding the role of culture in defining health. Culture at its most basic definition is a powerful social system based on a group's values, norms, and expectations. It's a communication and interaction guide for groups, ways of thinking, feeling, and acting. Culture informs how a group perceives health, wellness, disease, healthcare, and prevention. Hence the recognition that health values, beliefs, practices, and behaviors are culturally bound. Given the diverse cultures within the U.S., it is critical to understand how these concepts interact and intersect. Lack of awareness about cultural differences can make it difficult for both. In the next slide, we will note about the different cultural influences and the health-seeking behaviors and attitudes. And what we understand is that lack of awareness about cultural differences can make it difficult for both providers and patients to achieve the best, most appropriate care. Despite similarities, fundamental differences among people arise from nationality, ethnicity, and culture, as well as from family background and individual experiences. These differences affect health beliefs, practices, and behavior on the part of both patient and provider, and influences patient-provider interactions. All of these lead to clients being very uncomfortable with sharing information with providers in general. When it comes to sensitive issues, the barrier is sometimes almost insurmountable unless, as providers, we actively plan and address these issues with our clients. The medical community has focused on quality of care. Cultural competence has been woven into a framework that allows appropriate care for all patients. Quality of care supports adherence to a treatment plan, regardless of the patient's race, ethnicity, or cultural background. Also, patient safety has become another reason for engaging physicians and healthcare entities, such as hospitals, in a focus on cultural and linguistic competence. Next slide, please. It says, quit complaining and eat it. Number one, chicken soup is good for the flu, and number two, it's nobody we know. You know, that may be the case for health in our communities to some degree. In the next slide, I'm going to talk about cultural and linguistic competence and give a framework for how we approach cultural and linguistic competence. Systems, organizations, and individuals use a variety of terms such as sensitivity, appropriateness, relevance, responsiveness, etc. It does not necessarily matter what term an organization and its workforce is comfortable with. The most critical issue is that they are providing services in a culturally appropriate way. I use the term competence because it speaks to a level of awareness, knowledge, and skills that are measurable and can be evaluated to ascertain competence. Next slide. To respond to cultural and projected demographic changes in the U.S., by the year 2030, the Census Bureau predicts that 40% of the U.S. population will self-identify as members of diverse racial and ethnic groups. Currently, 4 states have a majority minority population. The second is to eliminate long-standing disparities in health status of people of diverse racial, ethnic, and cultural backgrounds. Divisions due to race are most commonly seen in the health status of the U.S. people. Third is to improve the quality of services and primary care outcomes. Delivery of high-quality care that is accessible, effective, and cost-efficient requires providers to have a deeper understanding of the social-cultural backgrounds of patients, their families, and their communities. To meet legislative, regulatory, and accreditation mandates, requirement for care to be delivered in a culturally and linguistically competent manner is increasingly emphasized by legislating, regulatory, and accrediting bodies. The fifth is to gain a competitive edge in the marketplace. Increasingly, we are finding that health management organizations are focusing on diversity as a way of increasing enrollment. And lastly, to decrease the likelihood of liability or malpractice claims. Next slide, please. So what is the definition? Definitions of cultural competence abound in the various disciplines of human services such as health, education, and social services. Like the definition for culture, there are many definitions for cultural competence. These variations highlight the difficulties in defining a framework that is organic and dynamic in nature. The term was first defined as a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals, and which enables a system, agency, and professionals to work effectively in cross-cultural situations. Linguistic competence is less debated and is more clearly understood by most healthcare system administrators and providers. However, in practice, the focus has been more narrow than delineated by its definition. The capacity of an organization and its personnel to communicate effectively and to convey information in a manner easily understood by diverse audiences, including people of limited English proficiency, those who have low literacy skills or are not literate, and individuals with disability. See, most often people think linguistic competence is a matter of translating documents and providing interpreter services, whereas the National Center for Cultural Competences, folks who developed this definition, had a much broader scope. Most organizations recognize the need for translated materials and interpreters. Rarely do they recognize that providing materials for individuals who have low literacy skills is a part of the framework of providing linguistically competent services. Next slide, please. Cultural competence is seen in a continuum from culturally destructive behavior to cultural proficiency. The one that I would like to focus on is cultural competence. Cultural competence views cultural groups as distinctively different. They also recognize that individuals within each cultural group have unique characteristics. They seek advice and consultation from minority groups. These agencies review policies and make changes to enhance services. They hire culturally diverse and competent staff and continue to support and train the staff. In culturally destructive behavior, this in the past has been forced assimilation, exclusionary laws, genocide, and though we think that culturally destructive behavior doesn't exist now, the use of children as interpreters and translators for their parents destroys the family power dynamic and in a way is culturally destructive. Incapacity is not having the capacity to provide culturally competent services, and in culturally blind organization, the notion is that if they provide equal services to all, they meet the requirement of providing care. Pre-competent agencies are beginning to think about it. They're beginning to assess themselves, and they're beginning to develop plans. And proficient agencies are ones who really become our mentors, our coach, our trainers, our teachers in our journey towards cultural competence. Next slide, please. Cultural competence needs to occur on multiple levels, but I'm going to focus on the organizational level and the individual level. On an in this framework that was articulated by Cross et al., there are 5 essential elements. 1, valuing diversity, and at the organizational level, this involves articulation of the vision, the mission statement, and integration into policy, infrastructure, and practice. 2 is having the capacity for cultural self-assessment. This would be the ability to recognize and conduct assessments and the resources to conduct those assessments. 3, managing the dynamics of difference, being conscious of the dynamics inherent when cultures interact and the recognition for the need to deal with cross-cultural interactions within the organization and develop protocols to respond to them in a timely and responsive manner. Institutionalizing cultural knowledge is to ensure that professionals within the organization develop the knowledge base to address issues of diversity and cultural competence. And lastly is develop adaptations to service delivery. This reflects an understanding of shifts in policies, structures, services, and values to provide culturally diverse services, services to culturally diverse clientele. Next slide, please. At the individual level, it's similar elements. Element 1 being awareness and acceptance of cultural differences. Second is assessment of one's own cultural beliefs, values, and prejudices. 3 is the understanding of the dynamics of differences inherent when cultures intersect. 4 is the development of knowledge of other cultures. And 5 is the ability to adapt service delivery to the cultural context of the individual, the family, and the organization. And in the next slide, we will see that these elements, these 5 elements, both at an organizational and individual level need to occur. But these elements also must be manifested in every level of the service delivery system. That is the policy making, the administrative, the practice service level, the consumer family level, and the community. It should be reflected in attitudes, behaviors, structures, policies, and services. And that is, in a very short period of time, a description of a framework for cultural competence. Thank you very much.
Thank you so much, Shaganya. That was a really informative and in-depth presentation that I think is valuable for a lot of organizations dealing with these issues currently. I'm going to turn it over now to Ms. Darby Taylor.
Thank you very much for giving me the opportunity to speak today and to talk to you about the efforts of our project called the Des Moines Healthy Start Project in Des Moines, Iowa. And I am Darby Taylor, and I'm the project director for Healthy Start. Next slide. To give you an overview of what Healthy Start is, we provide comprehensive home-based services to address health of pregnant women and families with children under the age of 2. We work with social services, parenting, child development. We have families that live in 9 targeted zip codes in Polk County, Iowa. And those zip codes are targeted because they have high disparate infant mortality rates among ethnic and racial minorities. We also utilize state funds, which we call empowerment funds, to expand our geographic area outside of those 9 zip code areas to all of Polk County, Iowa, and we can serve families until the target child or the youngest child reaches the age of 6. Next slide. Last year in our project, our case management services for the Des Moines Healthy Start Project, we served 671 families and just shy of 700 children, 682. There may be more children in the families, but those are our target children. Our case managers completed 8,000 face-to-face visits with families, and we employed 20 full-time case managers and 19 full and part-time outreach workers who are also interpreters. Next slide. To give you a little bit of a snapshot of Des Moines and of Iowa, the population of Iowa is just over 3 million. Des Moines is the capital city of Iowa, about 200,000 in Des Moines, but Polk County includes the suburbs and other parts of Des Moines, and that's 430,000. The Caucasian-only population in Iowa is over 91%. In Des Moines, that's a little bit lower at 76.4%, and primary language other than English in Iowa is at 6.8%, and in Des Moines is 16%. And on the next slide, we will talk about how it's a little bit different here in the Des Moines Healthy Start project. So of those nearly 700 families that we served last year, 30% were Hispanic, 24% identified as American, 34% were Asian, and 12% were African. Next slide, please. So you can see that we also had very linguistically diverse families as well. 29% of our participants spoke Spanish, 28% spoke English, 5% Arabic, and 38% spoke a language other than Spanish, English, or Arabic. Next slide. So as I said, English is the primary language of only about 1 in every Healthy Start participants. 38% spoke a language other than English, Spanish, or Arabic, which is a 21% increase just in the last 2 years. And participants spoke a total of 28 languages, which are included in the chart below. Next slide. Part of the shift in our population has to do with some refugee resettlement that happened in Polk County between 2007 and 2010. So you can see that there were 37 Vietnamese, 52 Sudanese, and 641 Burmese, which in a relatively small community like Des Moines, that's a fairly significant number. And during the last program year, we served 164 families who were from Burma or Myanmar and through the Des Moines Healthy Start project. Next slide. We had to do some creative outreach for staff to respond to the need that was changing within our program. So we currently have 6 full-time and 13 part-time outreach workers and interpreters, and they have a high school diploma or equivalent and are bilingual. And we currently have staff that speak 20 different languages and dialects who are employed by our project. Challenges, there were some challenges in recruiting and hiring. This really was spurred because we were utilizing outside interpretation services, which were very, very costly, and we could not afford them with our grant funding that we received. So we had to get into some communities and do some recruitment. We had an outreach team leader who spent the better part of the last several years making this a real focus of her job. And so in the beginning, particularly as we were trying to get Burmese as the first language on board, that was our biggest need with this explosion. She was going to churches and to grocery stores and to restaurants and just getting the word out that we were very much in need of an interpreter who could speak Burmese. And we were successful after some time, and we really needed the right person for the job. It couldn't just be somebody who was bilingual in 2 languages, but somebody who we could work with on confidentiality and appropriate boundaries and developing relationships. It's more than just somebody who can speak the language. So we were successful in finding someone who was out of state and agreed to come back to Des Moines for the summer, college student, and work for us, and then find a replacement when he went back to school, and he did that. And it just kind of snowballed from there, and we were able to get other dialects and languages utilizing that same technique. Another challenge is that, like I said, these are very small communities, and sometimes pressure is placed on staff. It's very common that our interpreters, outreach workers may know the families that they're serving, that they're interpreting for through personal relationships, and so that can also be a challenge as well. Next slide. We also have some diversity among our case managers. We have 20 case managers who are full-time currently. 8 are bilingual in English and Spanish, and 1 also speaks French. And 1 case manager speaks English, Arabic, and Nuba. And we also have a case manager who's dedicated to African-American families who reside in our Healthy Start project area. Next slide. One thing we really focus on in the Des Moines Healthy Start Project is staff recruitment and to make sure that we have the right people in the position. So starting directly from the interviewing process, we talk a lot about the project population and the diversity. We have lots of interview questions that address this issue. A sample that I've listed here is how would you respond to behaviors or customs that conflict with your own beliefs or knowledge of best practices, for example, as it relates to child rearing or discipline. And that's often a very interesting question and often sparks some very good discussion because we certainly want to support the culture and traditions of the families we work with. We want to ensure that families and children are safe, and it's often a very good place for us to start a conversation. As I said earlier, we recruit those outreach specialists right from the target communities, and they then help identify and recruit other community members and leaders to work for the project. We haven't had to do nearly as much intensive recruitment since we made some of those initial inroads, and we actually often have people come to us and apply for jobs here because they've heard about us working with somebody that they know or working with another outreach worker. We provide initial and ongoing education to both our case managers and our participants on how to work with outreach specialists and interpreters, because that's 3 people in a relationship, and so we actually have a guide for both the case managers and the participants, and we go through that and explain it about what it will look like, that the interpreter will wait for your case manager at your home and they will enter together, that the interpreter will interpret everything that both the participant and the case manager say to one another to make sure that they understand. The case managers speak directly to the participants when they're talking to them, things like that. So next slide, please. Staff training is also an ongoing effort that we do. We have monthly all-staff meetings which are attended by our whole team, so that's all of our case managers, all of our outreach specialists, other support roles within our Healthy Start project. And nearly every one of those meetings contains some sort of cultural competence information that we provide. That's often provided directly by our outreach specialists. They provide that formal education. They provide ongoing informal education about cultural awareness, things that we need to know to more effectively work with this population. They are a great and rich source of information for us, and we've learned tremendously from our outreach specialists. We also offer specific groups. We offer support groups or women's groups, nutrition groups, and parent-child interaction groups that target different populations. Those have been wonderfully successful. We're able to provide transportation to those groups. They're very well attended. The nutrition group in particular was targeted towards some of our Burmese moms. And we had a lot of fun with it and a lot of success with it as well. Did some visiting grocery stores, making up picture recipes, looking at play food to kind of explain what that food would look like, and really providing some neat education. Participants through our program also have traditional celebrations that we host at one of our locations. They often come in traditional dress. They bring the food, and our staff are invited to attend those. Just a rich source of education there as well. Those have been very successful. Families really look forward to those times during the year. And our program staff have been asked to attend and honored at some community celebrations. Next slide. Some of our depression efforts here, we screened 99% of the women in our project last year for depression. We have 2 licensed mental health therapists who can see our participants regardless of insurance status, which has been a huge benefit to us. And we also have a contract with a community-based psychiatrist, so if a participant is in need of medication, they're able to receive that through the psychiatrist. Next slide. Some of our cultural challenges, and these were touched on earlier, but recognition of depression or mental health as a problem. With our refugee population or our immigrant population, any of our population, they could have had previous experience in trauma, and so recognizing depression might not seem like a necessary priority or something that's really something there to worry about. There's a stigma sometimes associated with depression. The last bullet that I have here is starting support groups for Burmese women. It was critical for us to gain community buy-in, not just among the moms, but among community members of what we were doing and why we were doing it. Next slide. Domestic violence, only 7% of our participants reported domestic violence as an issue. We absolutely know that that's very, very underreported in our population. We also have some challenges with limited resources in a smaller community. We have one shelter. There's a lack of translated materials. There's a lack of interpreters. And we, at our organization, are often called on by other organizations to utilize our interpreters. There's just not a deep resource pool of interpreters in this community right now. Next slide. Some of the cultural challenges associated with domestic violence is the fear of being alone in a new country without the ability to speak the language. It can be very isolating, maybe culturally just very different in terms of domestic violence, lack of understanding of the system, what it means, if the police become involved, what sorts of things might happen. We provide a lot of education to our participants on these issues. We have learned from some of our outreach specialists that women becoming more independent can be threatening sometimes to men. We've also learned that there's an increased availability and lower cost of alcohol in this country than some other countries that our participants are coming from. We have had some just initial success, but we're a little bit excited about it, that presenting information related to domestic violence within a group setting rather than in a one-on-one has gotten some more disclosure from participants to feel a little bit safer as their peers are disclosing this, and so this is something that we will try to continue to build on. Next slide. Culturally competent service delivery, some of the challenges that we faced. With all of the referrals that we've received, we've had a wait list for some time now. Don't anticipate that going away. It's traditionally around 20 to 25 families, and we have a risk assessment that we use and some priorities about getting pregnant women in right away, but it's still a challenge. We'd like to be able to serve everyone who needs our services. Successfully linking the refugee and immigrant population to available community resources can be difficult or impossible. We need to do a better job at identifying resources so we can really address domestic violence with our participants. And as I said on the last slide, there can sometimes be a large burden placed on our staff by other community providers because there's just a lack of interpreters who speak this wide variety of languages community-wide. Next slide. Some of our successes, though, because we think some things have gone very well. We do have culturally and linguistically diverse staff who provide case management, parent education, and outreach. We continue to try to adapt to respond to the changing needs of the community, which is changing all the time. Our good depression screening rates and our access to mental health has been a benefit to staff, and we've really had a lot of success in hiring staff directly from the communities that we're serving and then utilizing those staff to provide ongoing education to others. Next slide. Just thought I would talk about some points to consider and where to start if this is something that you're considering or building upon in your own organization. We do have participants who face barriers to learning English. Certainly that breaking down that barrier is going to make things easier sometimes, but there are barriers there and they just need to be recognized. Many of our participants have spent their lives in refugee camps and they may have limited or no ability to read or write their native language, and so that can certainly be a barrier when we're talking about learning English. We also, with our participants, talk about how we think it's important to keep tradition and languages alive. You know, and empowering communities certainly will reduce dependency on services, but we think it's important to remember and to cherish and celebrate and to continue those traditions and languages. We have found that community members are just the best source of education, to ask questions, to listen to the responses, and then to be willing to utilize the information that you hear. And I'd just like to point out in the toolkit there's a wonderful place to start if this is something that you're looking to do in your own organization or program, and that's the Cultural Considerations tool on page 89. Next slide. And that is what I have today, and so thank you for letting me share about our project.
Great, thank you so much. I just want to say a special thanks to both of our presenters. I think they combined really nicely, and Ms. Taylor, I really am excited about the work that you've done at the Healthy Start program. It seems like a great real-world application of some of the issues that Saganya discussed with us previously, so thank you both.
Thank you.
All right, and that concludes our presenters representing other state organizations. In the beginning, Dr. Highsmith discussed the toolkit that Social Solutions International has been developing with HRSA for community-based organizations to address IPV and PD. And I'm just going to take a few minutes to briefly discuss some of the components in our Cultural Linguistic Competency section of the toolkit and how to implement several of these components that we describe. First, the toolkit explains what Cultural and Linguistic Competency entails, which requires organizational change and a commitment or willingness on the part of everyone in the system to undergo a transformation. This means from the leadership on down. Cultural and Linguistic Competency also requires staff to reflect and reevaluate their own health values, beliefs, practices, and behaviors. And it asks staff to acknowledge and address different social determinants such as oppression, suppression, bias, and institutional prejudices that really affect one's experience of health and health services. Cultural and Linguistic Competency really allows organizations and staff to be respectful of a person's experience and really meet them where they're at. And I think Ms. Taylor's experience really speaks to the type of quality services that they're trying to provide to the community and how helpful Cultural and Linguistic Competency really is. In the toolkit, we also discussed the HRSA-funded National Center for Cultural Competence, which was brought up in the presentations today as well. The National Center for Cultural Competence states that organizations need to work towards cultural and linguistic competence goals. This means they need to have a defined set of values and principles and demonstrate behaviors, attitudes, policies, and structures that really enable them to work effectively cross-culturally. This includes valuing diversity, conducting a self-assessment, managing the dynamics of difference, really institutionalizing cultural knowledge, and adapting to diversity. And those are topics that Saganya also touched on as well. This is just a graph to kind of explain the cyclical nature of implementing some of those goals. The toolkit also lists several resources. And I know you might be asking how an organization actually achieves those goals. And this is just a brief example of some of the resources that provide trainings and education. They provide standards of care and policies that could be adapted. The Community Toolbox of the University of Kansas also has some really informative trainings and tips for enhancing your cultural and linguistic competency in your organization. And the HRSA tool that I've listed below is also a great resource that has been previously used by HRSA grantees and could really be adapted for multiple organizations. In the toolkit, we also created a cultural considerations tool that allows individuals to conduct their own self-assessments and really identify their values and understand how best to manage the dynamics of diversity for their particular organization. So within that tool, the goals that we highlight for staff are to really understand the importance of cultural competency, have an agency-wide process that helps you to understand how cultural and linguistic competency can be achieved and why it's important. And we also provide the tool so that staff can share the diverse racial, ethnic, and cultural backgrounds that they represent. And staff can also understand how to utilize different language interpretation services that may be provided. The tool also prompts organizations to consider several other questions. We want staff and organizations to really be able to describe their vision for cultural competence, to sit down and think about the level of support that the leadership and staff will be able to provide in working towards this goal, and to really think about the primary cultural groups and languages that are represented in their community and by their staff. We also want organizations and staff to truly think about an organization's process for implementing translation services, for implementing different trainings on cultural and linguistic competency, and for really describing barriers that might exist towards implementing cultural and linguistic competency. And also want organizations to truly identify the needs that they have so that they'll be able to reach them. And finally, the Cultural Considerations tool prompts organizations to consider cultural and linguistic competency at multiple levels. And again, Saganya touched on this as well. It's not just the individual level that's important. It's not even just the organizational level that's important. It's also implementing this at the community level. And that's just a very brief highlight of some of the components that are in our toolkit. I want to thank everybody for their time today. If you have questions, feel free to contact Social Solutions. And if you have any questions or comments about the State and Community Intimate Partner Violence and Perinatal Depression Resource Development Project, please do contact Dr. Highsmith. Thank you, everyone.